Hey, this is Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and you might be wondering why I have a picture of a tree on this video, since we're going to be talking about teeth, as always. But I've been kind of racking my brain with how this week I feel like I've had this conversation like multiple times with doctors and lay people alike, and I'm trying to figure out the best analogy of explaining something that's super important. And this tree reflects that, this picture. I found this stock image and I purchased it because I want to show it to you. But, anyways, the question is, how do you know when to add IPR to an Invisalign treatment plan or a braces treatment plan or a clear correct treatment plan or whatever, some type of orthodontic treatment plan? Okay, well, let's take growing kids aside, because growing kids I can do magic with all kinds of appliances and growth and expanders. They're magical. Okay, so let's say patient is 20. Okay, let's say patient is 20. Okay, patient, hypothetical patient, 20 years old, healthy perio, lots of good bone, solid bone, but a lot of crowding, like maybe 15 millimeters of crowding, heck ton of crowding. Maybe like 20 years ago we would have definitely pulled 4 buys on her, but now everyone's a little more hesitant about pulling 4 buys, initially, because of airway, and they're not sure and they don't like it, and facial flattening and profiles and all that, right? As well they should be. There's all kind of things you should be concerned about. That was our go-to crowding solution 20 years ago. Now it's not. So now we've got IPR, and we're getting really accurate IPR, and there's great ways to stage it, and the treatment planning software can really simulate it nicely, and it's very accurate, and blah, blah, blah. So as you know, with max IPR, you can get up to 5.5 millimeters of spacing. Okay. Now, a premolar on average is 7.5 to 8 millimeters. 2 premolars together is around 15 to 16 millimeters. So, I mean, this is a third of a premolar extraction of what you can get in one arch. But still, 5.5 is good. That's a good way to get space. Nothing wrong with that. How else can we get space? So we got all sorts of decisions to make. Remember, I'm going to keep telling you this over and over again. And even the companies, Invisalign Technology, Clear Correct, Straumann, they're going to tell you the same thing. It's your job to direct the treatment planners and tell them what you want. They're going to just shoot from the hip, and they might just do what they feel like doing, or they might just do what the software tells them to do. Does it mean it's the right thing for your patient? No, they don't know your patient. They haven't examined your patient. From photos and a scan, they don't know what's best for your patient. They have not checked mobility. They have not checked root position. They did not take a CBCT. They did not take a CEF. I'm not saying you got to take all that stuff, but there's a lot of ways to get information at your disposal as a clinician when you see the patient in office that you can use to make an educated decision whether or not you should add IPR, or if it's okay to just expand and procline, which is your other option besides extractions, right? Or some type of combination. You can do extractions, that's probably off the table. You can expand the arches and procline the front teeth, get a lot of space through that. You can do lots of cool things with that if the patient is healthy enough to do that. Or you can add IPR or a combination of the both. It's your job to decide. Just because the software says it's possible doesn't mean it's possible. Okay, first of all, that means nothing. I can pretty confidently look at a treatment plan and be like, not possible. Just because they say it is doesn't mean it's possible, doesn't mean it's stable, doesn't mean if you do this, the teeth will stay for a lifetime, doesn't mean the bite won't open up, doesn't mean the teeth won't be mobile, doesn't mean the teeth won't fall out, doesn't mean there won't be pain, doesn't mean they won't need grafting. I mean, there's like 1,000 things that could happen, right? It's your job. So if you're not confident enough to make that decision, you really shouldn't, in my opinion, be doing this. I mean, I'm just going to say it like it is. You shouldn't be treating orthodontic patients if you don't know what the patient needs. Don't just let the 4-hour digital course tell you what the software thinks you need to do, because that's ignorant, to be really honest. So again, back to this tree. This was the best representation of how I feel about incisors, and when I needed to decide whether or not to add IPR, to push the tooth forward, to pull the tooth back, to expand the arches and make space that way, or a combination of all of the above. Now, this tree right now, it's probably doing pretty well, right? but you can see it's at the edge of a cliff. And that's almost how your labial bone is on a patient, right? So some patients, we got plenty of bone. We're good. We can push it forward. No problem if they're healthy, if they're young. Even older patients, we can sometimes do that. How do you tell? Sure, you can take a CBCT. That's a little bit invasive. I don't know if I want to irradiate a patient just for that, unless I really had to make a decision. Sometimes I can tell from a Ceph. Not everyone, again, needs to take a Ceph. I can look clinically for the most part and use a combination of perioprobings, x-rays, is there mobility, just looking at the roots, are they scalloped? There's a lot of different ways I decide. Patient feedback. Hey, how do you want your profile to be? Do you want your teeth to move forward? Do you want to have a fuller profile? Do you want to have a flatter profile? You know, sometimes there's choices to make. Often we don't even have these conversations with our patients in the chair. We just kind of make a judgment call, and that's that. But basically, I just want to explain to you that, for example, let's say we put a force on this tree. Okay, let's say it's a really windy, snowy day, icy day. What's going to happen to this? It's probably going to fall over, right? It probably is. It's not going to be stable because there's not enough dirt on the front end, just like it is in the bone, you know, of this tree. What if this tree was replanted back here? It might not fall over, right? So now you get what I'm saying. It's really important to set your teeth in a nice amount of bone and to make good clinical decisions about where to put the teeth. Just because the software says you can expand and procline doesn't mean you should. Doesn't mean it's possible. Doesn't mean it's stable. Doesn't mean the patient won't need grafting. Sometimes that's fine. You've had that conversation with the patient. You say, hey, you realize if we do this, we might be, invading the biologic width. We might be pushing the teeth beyond their boundaries. They might get a little bit loose. If they do, we'll keep an eye on them. We can always add some IPR and tuck it back. We call that round tripping. That's fine too, as long as you're keeping an eye on the patient. For this reason, I think it's really important that you do have some type of monitoring on your patient. Don't just give them 5, 10, 20, 30 aligners and say, bye-bye, see you later. You need to be monitoring them, on an super easy case. Sure, put the attachments on, do the IPR if you need it, give them their 10 aligners, bye, check back later. We'll be checking in virtually every 2 aligners, every 3 aligners, have a virtual check-in program. Totally cool with that. On a difficult patient where you need to be monitoring mobility, the attachment loss, discomfort, perioprobings, bone level, there's so many things you need to be monitoring. I don't think there's any way you can do that remotely totally. You need to see them in office at least, I would say, every 5 to 6 aligners, just to check, especially if it's one of those we're not quite sure kind of patients. So basically, again, I just wanted to show you this picture, and I hope this picture will stay with you when you're making your treatment decisions about where to put the teeth. Don't let the treatment plan dictate treatment. You're the doctor. Make your own clinical decisions, and don't let patients dictate treatment. Oh, I don't want IPR. I feel like this week with doctors I've worked with, that has come up like a ridiculous amount of times. So patient doesn't want IPR. Okay, well, does patient want to lose their teeth? Because if we just push, there's much more chance they're going to lose their teeth. What's going to happen if your patient loses their teeth? Okay, yeah, if you had that conversation, patient really, really wanted to try, they realized the risks, they signed off on an actual treatment plan where you say, hey, here's the risks, and they sign off on it, you're probably okay. Patient loses the teeth, patient got to buy some implants later. Sometimes that's going to work out. Sometimes the patient's going to make a big stink about that, saying you didn't explain it well. So when push comes to shove, if they take that to the courts or they appeal insurance on that, unless you did everything the right way, hey, yes, I did this, I did that, I discussed this, here were the options, patient chose this, here's how we monitored the patient, here's how we checked, this is what we did at our appointments, this is what we did at our virtual appointments, you're in the clear, you're fine. But unless you did cover all your bases, I didn't add IPR because Invisalign said I didn't have to. Wrong answer. So, wrong answer. You're the doctor. So, anyway, sorry, small rant, but I feel like it's come up so often lately where doctors are being swayed by patients to do treatment plans that are invading the biologic width, making poor clinical decisions because patients are pressuring them, or the patients don't fully understand the importance of having their teeth in a lot of nice bone. And yeah, periodontists, feel free to to chime in. I have a feeling there's going to be a lot of periodontists doing a lot of work in the next 20 years with a lot of these ortho cases that are going to head south, and the teeth aren't going to stay because we just pushed them too far. So maybe it's a good career to go into. All right. Hope someone listened to this. Thanks.